Good evening and welcome to this series of strategic primary care focused conversations we've been having for the last few months. We've called these the future of primary care. I'm Mohit Venkataram, and I'm the Executive Director of Primary Care at East London Foundation Trust. When we set up the primary care division at East London, it was set up as a testament to the amazing work carried out in primary care. It would not be incorrect to state that much of the NHS structure runs efficiently on the exemplary provision of primary care. And it's for us, in our roles as large NHS providers, to recognize that we should be supporting primary care resilience by sharing the corporate resources that are available for all of primary care. This series of conversations that we've been holding for the last few months features eminent movers and shakers. Called The Future of Primary Care is one such attempt so we can all learn and grow together. After all, we serve the same residents. The pandemic has taken a great toll on all of us, and many of our primary care colleagues have made the ultimate sacrifice to ensure that we were collectively safe. These leaders, namely Dr. Habib Zaidi from Leon-C, Dr. Fayaz Ayache, Dr. Syed Ishan Haider, Dr. Kamlesh Kumar Mason from Basildon, Dr. Krishna Gopal R from Croydon, Dr. Yusuf Patel from Newham, Dr. Craig Wakeham from Dorset, Dr. Karamnath Ullah Mirza from Clacton-on-Sea, Dr. Purnima Nair from Durham, Dr. Mohinder Datta from Slough, Dr. Abdul Razar Abdullah from Havering, Dr. Thomas Ullman from Leicester, Dr. David Wood from Llandudno. These were doyens who illustrate the shining examples of sacrifice made by primary care on a daily basis. I would like us to dedicate today's session to these wonderful people, but for whom we would not be saved. Our guest speaker today is Professor Martin Marshall. It's a name that needs no introduction in primary care. GP extraordinaire, system leader, recognized voice in healthcare, chair of the Royal College, to name just a few of the fantastic things he has done. In today's format, we will request Martin to take about 10 to 15 minutes and share his views on what primary care would look like in the future. We will then have an open session on question and answers. Please use the chat box function to drop in your questions. I'll try and summarize the themes of the various questions that are presented so that we can best make use of this hour that we have together. Martin, welcome, and thank you so much for your time over today. Over to you.
Mohit, thank you so much for your kind introduction. It's a real pleasure to contribute to this webinar, and thank you to everybody who's joined this evening. I'm sure you've got good things to do on a lovely August evening, so the fact that you're here is a real testament to your amazing contribution to general practice and your commitment to your profession. And I have to say, I'm incredibly moved when you gave that list of names of people who've given their life for their patients, for their communities. It's extremely moving. So let me tell you a little bit about myself very quickly before I kick off. So I'm a GP in Newham. I've been there for about 8 years now. I've also been a GP, salaried GP in Moss Side in Manchester. And before that, I was a partner in Exeter in Devon. So I've worked in 3 different parts of the country, quite contrasting, really interesting. I've developed an academic career alongside my clinical career. So I've been Professor of General Practice. I'm now Professor of Healthcare Improvement at UCL. So my interest is in research. Specifically research into quality improvement work. And I've also had the, I'm not sure whether pleasure is the right word actually, the pain of working in government. I was a senior civil servant and Deputy Chief Medical Officer with Liam Donaldson. And that was a really interesting experience, and maybe we'll talk a little bit about that. What it gave to me was, I think, a helpful understanding of the policy making process and the political process, which as chair of the college I'm now trying to influence. So it was a very useful experience for me. I've been chair for just over 18 months, so I'm just over halfway through my 3-year term. And it's been a racy 18 months, I have to say, with COVID and with the significant crisis that we're seeing in general practice at the moment. And that's what I want to talk about. As Merit said, I'd like to just say a few words on what I think general practice will look like in the future. And I think it's important to do that at a time of crisis. And I don't doubt for one second that general practice is going through a significant workload crisis at the moment, a crisis which is impacting on all of our ability to do the job that we were trained to do, our ability to be able to look after patients effectively in the way that we want to and they want to be looked after, and our ability to look after our communities as well. This isn't the first crisis that general practice has gone through. I've seen a few in my professional lifetime. I've been a GP for 33 years. I guess the biggest crisis general practice has ever seen was in the 60s, where 25% of GPs actually did emigrate to Canada and Australia, New Zealand. They didn't just threaten to leave or retire early, they actually left. That was a massive crisis. It led to a massive investment in general practice, which had a significant impact over a 20-year period. We saw a similar crisis in the 1990s, mostly a funding crisis, which led to the new contract in the early 2000s, which again invested a lot of funding, a lot of resource into general practice, helped general practice to develop a new model. This crisis has been exacerbated by COVID, but it's a crisis that's been 10 years in the making, probably. And as far as I'm concerned, there are a number of reasons for it and a number of elements of the crisis, but the principal problem is that demand exceeds supply. It's as simple as that. We have a massive amount that we can do and want to do for our patients and our communities. We have increased demands being placed on us all the time, and there simply aren't enough GPs and other health clinicians working in general practice in order to meet that demand. So I suspect we'll spend a long time talking about that. But at a time of crisis, it seems even more important that we're clear about where general practice is going. And I hear this particular from early career doctors, who many of whom express concerns, fear even, about where general practice is going and whether general practice has got a future. And that's really worrying. When you're starting your career, you've committed your career to a fundamentally important medical specialty, but you're not actually confident that it's going to exist, or you're not sure what it's going to look like during your career. So I want to talk about what I think general practice is going to look like, how it's developing. There's nothing particularly clever about it. I haven't got a crystal ball that's any more effective than your crystal ball, but what I'm doing is looking at the trends that we've seen in general practice. And I can see probably 5 or 6 trends that I just want to talk through quickly, which I think illustrate where we might go. The first one, obvious one, it's scale. General practice has changed dramatically from very small scale, people used to call it corner shop scale, to a much more diverse set of structures and governance arrangements, but basically operating at larger scale. And that operation can sometimes be through voluntary or relatively voluntary partnerships like PCNs, I guess, up through to big for-profit corporations run by international companies. So a very wide range of different models that we're seeing in general practice, much more heterogeneous than it used to be. Is that a good thing or a bad thing? I think it's both, actually. For me, the front end of general practice has to be small practices. It has to be practices with a sense of responsibility for a local community, where trust can be developed, where you can develop a knowledge and understanding of your patients and your community, and you can work effectively as a team. So that front end of general practice, small is good, but actually not having a back end, not having an infrastructure to support general practice has been one of the major impediments, I think, to our ability to be able to develop as a specialty. So I'm really excited when I see models like ELFT, for example, and other larger scale models where you've got an infrastructure, you've got good data, you've got analysts, you've got HR people, you've got contract people, you've got a whole range of support systems which any modern organization kind of needs in order to be effective. So the expression that I hear, which I really like, is you've got to get big in order to stay small. And that feels to me to be just about a nice reflection of where general practice is. So scale is the first big shift, and I think that's going to continue. The second big shift is multidisciplinarity. So when I became a GP in the late 80s, about 85% of the consultations were delivered by doctors. We had some practice nurses, but that was about it. That was the primary healthcare team. Very different now. Only about 45% of all consultations in general practice are delivered by doctors, and 55% of them delivered by other health clinicians, and a massive range of them. Nurses still, of course, but pharmacists and physician associates and healthcare assistants and mental health practitioners and physios and a whole range of others whom I've probably insulted by not remembering to mention them by name. A really important multidisciplinary team. Is that a good thing? Actually, I think it is. You know, what we know, it's a pragmatic thing. If you can't get GPs, you need other clinicians to deliver the work, but it's more than that. What we see from our clinical colleagues, our non-doctor clinical colleagues, is a remarkable range of skills that we bring to serve our patients and our communities in an effective way. So I think it's exciting. I think there's an interesting debate to be had about how doctor-heavy general practice should be as a specialty, and I've made cases in the past that the expert medical generalist, the well-trained GP, is a fundamentally important part of the team, and probably a very cost-effective part of the team as well. But I think in general, multidisciplinarity is going to be something that we're going to continue to see, and probably actually we're going to see a growing number of specialist disease-based consultants working in general practice and primary care as well, rather than being locked away in their hospitals. They're going to be coming out more and working in partnership with us and with our teams. So that's the second significant trend that I see in front of me. The third one is the use of technology, and in particular technology for consulting. So there's no God-given message that general practice had to be 10-minute face-to-face consultations, and yet for some reason that seems to be the model that we've developed and we've stuck with. What we've seen as a consequence of COVID, and general practice has done a truly remarkable job at adapting to the pandemic, embracing these changes so rapidly and so enthusiastically. What we've seen is a whole range of different ways of providing care for people, whether it be by telephone, a technology that's been around for 150 years, hardly a new one, whether it be by video, whether it be text-based, whether it be synchronous or asynchronous. Still believe that face-to-face is fundamentally important. Now, around about 55% of consultations in general practice are delivered face-to-face, according to data from our own systems and from NHS Digital. So it's crept up a lot from the 10% at the height of the first wave of the pandemic. Who knows where it'll end up, we're not sure. But what's clear to me is we're going to be much more flexible in the way that we deliver care for our patients, in a way that meets patients' needs and is convenient for patients and is convenient for us as clinicians as well. So I think the use of technology is important, not only for consulting, also for remote monitoring, for outpatient services, for triage, a whole range of different ways that we'll be continuing to use technology more and more effectively, and probably a little bit of AI as well. It would be interesting to see how artificial intelligence comes into the decision-making process in general practice. So that's the third significant change. The next one is about our relationship with patients. I think GPs have never been in the kind of doctor knows best place. We've always wanted to work in partnership with our patients. We've understood the importance of shared decision making. What's clear to me is shared decision making is becoming much more sophisticated, and general practice is in the lead of developing that. It's a big cultural challenge for the medical profession, which tends to be sometimes a little bit dominant, not necessarily seeing patients as experts in themselves. for me, the consultation is a meeting of experts, a medical expert, me, and an expert in the life of the individual patient, the patient in front of them. And that's what's great about the general practice consultation. So I think we're going to see much more shared decision making, much more sophisticated data-driven approaches towards shared decision making, and a different kind of power balance between doctors and patients. So that's a fourth one. The fifth one, I think, is going to be a stronger community orientation. So you'll know 3 different models of general practice that we talk about, that we teach. We talk about a biomedical, a disease-based model. We talk about a psychosocial or a biopsychosocial model, the whole person model that's very much part of general practice. And we talk about the public health model. I think as GPs, we've been really good at developing the first 2 models. I think we've been less good, by and large, in developing the public health model, the population-based model. But I'm seeing, partly as a consequence of COVID, I'm seeing growing numbers of practices really getting into social determinants of health, utilising social interventions, really getting into addressing health inequalities in their populations and communities, really getting into utilising, building on community assets. And I think the community health improvement role, or public health role, population health role, whatever you want to call it, of general practice is going to become a significant part of what we do as clinicians. How we create space for that might be something that we'll discuss when we get to the Q&A, but I think that's important. And then the final area, very quickly, is just integration. So the NHS was designed in 1948 in 3 silos: hospital silo, a community silo, and a general practice silo. And by and large, we've remained in silos. And we as GPs, who have to help patients through transitions between sectors, really see that fragmented care. And let's face it, patients certainly see the fragmented care, often having to repeat information, often losing information in transit. So, whilst I know there are some downsides to some of the recommendations around the integrated care initiative and the bill that's currently going through Parliament, I'm actually very excited by the principle of having a much more integrated system in which general practice is a key, probably actually the centre of the way the whole system operates. So those, I think, are 6 changes that I think are trends. I think they're trends that will continue. Some of you might like those trends, some of you might not like them, or might not like some parts of them. I actually think they're inevitable. I might be wrong, but I think they're inevitable, and I think our job as leaders of our healthcare system is to embrace them and mould them in a way that best suits our needs in general practice and the needs of our patients and our community. So, Mohd, I hope that's a helpful introduction. Very happy to have questions, answers, and discussion.
Fabulous, Martin. As usual, riveting. Whatever you say is so topical and so wonderful. And I think there's a lot to be said for what you've just shared. And I think I'll start by a couple of questions that have popped across to me directly in the chat box are ones around the shared decision making you were talking about, Martin. And I think that is the model that general practice has been known for. It's a fabulous model. It works really well. But co-production in the new world is more about empowering and helping people manage their conditions themselves. It's about prevention. And a current model of general practice that's been set up, from the contract to even the way it operates, the core, doesn't always support population health in the same format as they are being expected to do now. What do you think we can do, Martin, to support primary care so that they can be the leaders? Because in reality, population health is best dealt at GP level.
Yeah, I think that's absolutely right. Are there enough incentives in the system currently to encourage a population health perspective? I think you're right, probably not. Although having said that, actually QoF does that. QoF is about improving population health one patient at a time by improving their long-term condition management. So there are some incentives in the scheme, but actually the fact that the way that we're funded through the capitation model and through items of service and through quality payments like QoF doesn't necessarily encourage people to stand back and think more strategically about what are the needs of our community, how do the needs of our community differ from the needs of the community next door in another part of the country. How can we plan for the needs of those communities, understand and plan for the needs of those communities? I think you're right, it doesn't do that at the moment. So we need a different funding model. We need to have different partners. We need to work more effectively and more closely with colleagues in public health. That could be a little bit of a challenge at the moment because public health has been stripped bare since it moved into local government. I don't think the move into local government was a bad thing. I think in many ways it might have been a good thing, but the fact that it moved into local government at a time that massive cuts were made in local government, I think is a real problem. So we need to work closely with public health colleagues. We need to work, I think, much more closely with community groupings that exist within our communities. In Newham, we've got amazing, vibrant community groups who really are experts in the nature of health and health problems within their communities. We need to work more closely with them as well. So I think there's a lot of things that we need to do. I think probably our training needs to improve in public health and population health as well. I don't know about you, but when we did public health modules at medical school, I think I might have gone on holiday. I don't remember one. I certainly don't remember engaging with it particularly, and it's only later in my career I've become much more interested in the potential contribution that we can make to improving population health. I think we need some training as well, but I think we've got a massive contribution to make because no one knows their communities as well as GPs do.
Very good. Absolutely the way to go. I think, Martin, I would hate to share what I did for my public health module when I was in medical school because my kids are around and I don't want them to know what Dad was up to. But it's a fact. It's an absolute fact. That's exactly what we did. And I think there's a lot to be said how this training has to be strengthened going forward in terms of how people see it. I think there is also this increasing thought that's coming out, and a couple of questions seem to touch this in different ways around how do we keep general practice to continue to be led by local GPs, not led by wider interests, not led by people who really don't understand the market, because there have been different case scenarios. Yeah. And there are some really good examples of GPs coming together and forming consortia, but there are also some poorer examples of people from wider ownerships, people from backgrounds they don't understand, and sometimes even international people coming with an interest in the practice. And there is something to be said about the NHS being owned locally. And what's your view on that, Martin? How do you think we can support that?
Yeah, I agree entirely with that. I think local ownership is fundamentally important. I guess it leads on to the bigger question that maybe we'll discuss more later about the role of integrated care organisations and whether integrated care systems and integrated care organisations, as we're seeing them developing at the moment, really understand how important general practice is. So I've done a lot of evaluations of integrated care organisations across the world in my academic role. And it's very clear that systems that are well integrated deliver better outcomes at lower cost, first of all, and they always have general practice at their heart, or primary care if it's in the US or whatever, but they have the generalist at its heart, not specialists, not hospitals. And there's a real concern with ICSs, particularly in East London, I have to say. I know some of you are from East London. There's a real threat, I think, that our ICSs will be driven by the Bart's, Royal Free, UCLH type model view of the world, and that to me would be a disaster. So one of the things we're doing as a college is lobbying very hard to make sure the general practice voice is central at an ICS level, and we've got that into legislation, which is good. One voice or a few voices isn't enough, but it's a start at least. What really matters, it seems to me, in terms of integration is not what happens at an ICS, a high level, a regional level. It's what happens at a local level. It's the integrated care partnerships. And within East London, we've got some really, particularly in Tower Hamlets, actually, some really interesting and powerful local partnerships between local consultants and local GPs, patients at the centre, redesigning services together. That's the bit of integrated care that really excites me. That's the integrated care that will touch on our lives as clinicians and on patients' lives as well. So I think we need to really get involved in this new integrated care system. We need to get involved in influencing the policy. We need to make sure we're at the centre. We can't afford to be marginalised, because if we are marginalised, then the whole health system is going to be set back by a long way. And we're not going to see what we need to see, which is a significant shift in funding. So at the moment, general practice does 90% of the NHS work for around about 8 or 9% of the total budget. If you look at effective integrated care systems in Israel or Sweden or some of the leading systems in the US, you'll see primary care 20 or 25% of the budget. Those are the kind of figures that we need to be aiming for. And we'll only get that if we're at the centre of the decision making in ICSs, because they're going to be holding the budget. That's where we need to be.
It's a really stark statistic, isn't it? Where 80 to 90% of the work is done in general practice, but only about 10% of the funding comes to general practice. And that shows the disparity and the lack of equity in terms of how it's being held. And what's your view about the GPs? Because in the new ICS agenda, there seems to be a lot of conversation about there being a primary care seat, but a primary care seat doesn't really represent the GPs and doesn't really get the breadth of voice that the current CCG structures had, or even the previous PCTs had. So I think something to be thought about. How do you see the role of RCGP or even the wider community in terms of the leadership standing up so that GPs have a stronger voice and primary care can drive the ICS integration agenda?
Yeah, I mean, you're right. It's a real challenge. I think CCGs, whether you like them or don't like them, have given a strong voice for general practice. When you realise that general practice has been essentially dictating where the funding goes through commissioning, that's been a massive influence on the system. So with the demise of CCGs, how do we have that influence? I think for now, at least, it's going to happen through PCNs, but PCNs have to be properly resourced. CCGs had a reasonable infrastructure budget to allow them to create time, clinical time, for example, to influence commissioning decisions. That doesn't exist in PCNs at the moment. So we are lobbying very hard to make sure that PCNs are properly resourced to work either individually or across PCN boundaries in order to be a loud voice in the system. That's going to be really important. The one clinician, I think you're right, Mohit, although the guidance at the moment in legislation, which is going through Parliament, is that there will be a very small board, and only 3 mandatory people on that board, one of which is a medical consultant, a hospital consultant, one of which is a GP, and one of which is from local government. So given that that's all that's in legislation at the moment, our view was, well, having one GP on there, which isn't something they originally recommended, they weren't going to have a GP, having one GP on there actually is going to be quite a loud voice at that central level. But as I say, that is where maybe funding flow decisions will be made. But actually, the real work will be done at an integrated care partnership level, at a much more local place level, whatever you want to call it. And that's where I think most GPs will want to get involved in redesigning services, working with specialist colleagues and working with their communities.
Fabulous. And there is this increasing concern. I mean, a couple of people have put some questions on that also in the chat box, Martin, around what's the future of practices? Do they have to be large to be beautiful? Or would small practices still have a place in the future? Because increasingly there is noise about large is beautiful. And there is this concept that what will PCNs also do in the future? Because both these bodies are meant to work together, but often there are different powers and different allocations that are happening at that level. How do you see it pan out in the next few years?
Yeah, so just going back to what I said earlier, I think big isn't necessarily beautiful, but big is good in so much as it allows you to have an infrastructure support for what frontline clinicians do. And I'm very aware. The practice that I work in Newham, which is Liberty Bridge Road practice, is part of the Hurley Group, which is a London-based group, mostly working in deprived areas. Currently got about 14 or 15 practices, and having an HR group level, having finance at a group level, having data and quality improvement at a group level, that kind of infrastructure is really important to our ability to be able to function as a practice. It allows us to do things in I don't want to use this word, but a more professional way in many ways, actually. Being able to have an infrastructure that allows you to do stuff that you just wouldn't be able to do if you were much smaller, I think is important. But as I said, the front end of care, the care that patients experience, must remain small. I think that's a fundamentally important part of general practice. We serve communities, we understand communities, we have personal relationships with our patients. And if you have too big a provider, you lose that personal touch. And we can see that in some of the very big primary care providers. So I think there's not an incompatibility between small front end and larger back office function. And I think that's probably the model that we'll be heading for. Now, how small is an interesting question. So do single-handed practices have a future? Well, if they're good, yes, is the answer. I think there'll be fewer and fewer of them. We see far fewer now than we used to. We've got more in East London than in many other parts of the country, but they still exist. And if you look at the evidence, generally speaking, smaller practices deliver much more personal care. They get higher ratings in terms of patient experience and patient satisfaction than larger practices. Larger practices will sometimes do some of the more technical stuff more effectively than smaller practices. So there's a trade-off, if you like, between big and small there. I don't think we should get rid of small practices out of some kind of ideology or some kind of misplaced view that they can't do their job, because some of the best practices that I see in my area in Newham are what you might regard as very traditional, very small single-handed family practices, and yet they know their patients, they deliver the most brilliant care. So I don't think we should get rid of them for any ideological reason. The other issue about scale that many people talk about is larger scale gives you greater efficiencies, and I don't believe that for 1 second. Actually, I think there's something about small scale and ownership, a sense of responsibility, that creates amazing good value and goodwill. And I think actually government has started to realise that, having originally thought that get it big and have a small support system and everything will be much more efficient. They're starting to realise how important goodwill is in general practice. And that's one of the reasons why government has suddenly become much more enthusiastic about the partnership model than they might have been 5 years ago.
And I think you're absolutely right in what you say, Martin, around big not always being beautiful, but they all bring something different, and each of them bring a different color to the rainbow, and they bring this vibrance together, and small and big together, learning from each other, bringing something different. I think there is also this view that often small practices don't provide good care, and as you said very, very articulately, it's not about the care, it's about the corporate supports and the resources that exist behind this: QI, HR support, finance support, things that as a doctor, none of us were trained to do. And we are suddenly being thrust to do it in small general practices. I mean, you suddenly become a chief exec of a small organization in a way, if you're running a small practice, and it's really hard because where do you give your time to? So I think you put it really well in terms of how you see it. And I think many of us would share that sentiment. There is also this thing in East London, isn't it, where the latest report on equalities showed that GPs from ethnic background were more likely to end up with an inadequate rating or an RI in the CQC. And it was a bit of a shocker, but it wasn't something that should shock us, because actually we have seen a number of different facets of inequality resulting from various things. So perhaps something to prepare. And I know as the chair, you took a strong stance. Actually, you went out to speak about it. Just wondered if you wanted to share some thoughts on that and what we should do next around supporting to get a better primary care resilience system that we can all trust in.
Yeah, this is so important. Inequalities, particularly based on ethnicity and race, are such a massive impediment to our ability to be able to deliver fair, equitable care. And I think the fact that we're seeing these disparities in things like CQC ratings is worrying. Now, I don't want to take this at face value here, because I don't think we fully understand the way in which CQC works. We, as a college, have challenged CQC about the headline figures around a disproportionate number of practices run by ethnic minority practitioners that are rated poorly by CQC. And I have to say that CQC have responded constructively and positively to the challenge. We've met them with our Black, Asian and minority ethnic advisory group in the college on a number of different occasions. CQC have established a working group in order to understand what's going on. They've accepted the challenge that they don't have enough data to understand exactly what's going on within their regulatory model. They've accepted that. They haven't accepted that there's frank discrimination, because they simply don't know at the moment, but they're very active in terms of supporting and managing their inspectors to help them to understand some of the issues around illicit practices in particular. So I think there's a lot of unanswered questions here. We know that unfairness exists, we know inequality exists, we know discrimination exists. We don't know exactly what the causes are, and we don't know what the relationship with CQC ratings are at the moment, but we're pushing hard to try and find out more. And I think it's really exciting, this agenda generally, not just with practices run by people from ethnic minority backgrounds, but more generally in terms of the way that we support our ethnic minority communities. The fact that that is now high profile and everybody's talking about it, and the fact that me, as a middle-aged white bloke, is saying stuff out there, highly supportive of greater diversity and greater fairness. I think just kind of it's a reflection that as a society, at least we're heading in the right direction, even if we've got a lot of massive challenges to face.
I think having your allyship is brilliant in this, Martin, because we do need people talking about it, and the more we talk about it, the more likely we will get this out of the way, because it really has to be resolved. And you're right in what you say around, we need to understand this a bit better, because this is the report on face value. But we need to go behind this to really understand what the figures say and how we make that difference in the long run.
Yeah.
There's also this big figure that's bandied about, isn't it? 2,000 GPs are going to fly and save the world for the NHS. And we've all been waiting for that to happen for some time. And I think we will be waiting for a bit longer for this to happen at the current rate. I think some of the planes have gone to other countries to support them right now. So I think, Martin, how do you see us really grow our own? Because that really is the answer. How do we support the young GPs to come up and take leadership? How do we support people from wanting to become GPs? What do we do to invigorate this profession? Because it is a fantastic profession. It's one like no other country has in the world.
Yeah, exactly right. I mean, I still think it's the most stimulating and exciting job to do. And I have to say, although I've done a lot of different things in my career and I haven't been a full-time GP for a very long period of time, I still enjoy my clinical work more than I enjoy every other part of what I do. So it is a great job. There's no doubt about it. However difficult it is to do at the moment. You're right. The targets have been set. We know we haven't got enough GPs. The target of 6,000 extra GPs by originally 2021, now 2024, has been set in 2015 and then again in 2019. Where are we in terms of hitting that target? Absolutely nowhere. In fact, we've got fewer GPs now than we had in 2019 and 2014, if you look at whole-time equivalent GPs. So we've got a massive challenge here. One of the ways of addressing that challenge was to try and bring in more doctors from overseas. That hasn't worked, as you say, Mohit. I understand about 18 doctors have been recruited, not 2,000 doctors. This is across the whole of the country. And the reason for that is, is fairly clear that there's an international workforce crisis in healthcare. Every country's got problems. So, we can't steal doctors from somewhere else in order to address our challenges. Although, having said that, I will come back to a way in which that is actually happening. But I think the issues here are number one, recruitment. So how do we need more medical students, first of all, in order to be self-sufficient. And the number of medical schools and medical school places is growing. And the good news is that a lot of those medical schools are being placed in areas of high deprivation, because there's very good evidence if you train a doctor, they carry on working in the community that they trained in. So we're hopeful that some of the doctors that are in parts of Essex, in the Northeast, in Liverpool, new medical schools are going to stay in those areas. It's a long way away, of course, but that helps a lot. So that's kind of good news. In terms of GP places, as a college, we've lobbied very hard to increase the number of GP places, and we've done so very successfully. This is the big success story in the workforce. So we've now training 4,000 GPs a year. So we've got 4,000 training places, and those training places are extremely competitive. So for the first time, every single VTS is full, and in some places highly competitive. So general practice has become an attractive career for young doctors, which is really great, and we're continuing to lobby for more than 4,000. We're starting to irritate our consultant colleagues who are also short of doctors, oncologists, pathologists, respirologists. There's a whole range of other shortage specialties, but we're doing really well for general practice. So the front end, the recruitment end, is really good. The retention end is where the problem is. So it's as if we've got the taps full on, but the plug's out of the bath, or even actually the bath is cracked, because more and more people, because general practice is such a tough job, are either working very part-time or retiring early. And in fact, I'm 60 in a week's time. Can you believe it? There you go. Most of my peer group, the people that I trained with in Exeter, where I did my vocational training, have now retired. I'm about the only person left working in my peer group, and that's just common. A lot of people in their late 50s and early 60s are retiring because the job is so tough. So until we address the workload crisis and make general practice a more doable, a safer, more doable, more enjoyable job in the way that it used to be, then we're going to have a lot of trouble holding on to people. I often draw the analogy between when I started as a partner in the late 80s. On a busy day, I was seeing probably 22 patients a day. Now I'm seeing probably 60 patients a day, and there's no way that I can be as safe or as effective a doctor with my 55th patient as I am with my 5th patient. And I think we just need to recognise that and be very explicit about it, and that's what we're doing. So we have to reduce workload in order to increase retention and help people to want to work more in clinical practice, and help people not to want to retire prematurely when in many ways are at the height of their career. Now, just the height of their professional powers. So just coming back to the international graduates, actually there is something happening here which is really interesting, which is that a significant proportion, probably around about 30% nationally, of the 4,000 training places are filled by overseas graduates, mostly from the EU, but also from other countries as well. These are really good people. They've passed all the criteria to get into training schemes, so the bar is high and they've got in, so they're good people. The big question in my mind, though, is will they stay when they finish their training? And that's so we can laud and be very pleased with 4,000 training places a year. In 3 years' time, that's going to result in a much larger workforce, growing workforce over the years, but only if we manage to hold on to those international graduates, so they don't want to just go back to their country. So that's going to be an interesting challenge. We'll have to see how that plays out.
Fabulous. It's the first time you've all heard it, folks. All the VTS places are full for general practice. What more can we ask for? This is fabulous news, Martin. I think in my 30 years, I've never heard that before. So I'm so pleased hearing this. I think one of the other things people often talk about is the independence of GPs, whether they call it they are private practices, they're businesses on their own, or they talk about the lack of the ability to implement changes easily around saying policies are different, each practice operates in its own way. And while it does bring a colorful variance to the system, the ICS is more about uniformity. How do you get general practice to do exactly the same thing so there's co-production, equity happens? How do you get them to use the same IT system so that it integrates? How do you get them to report in the same format?
Yeah.
And there is some dissonance in the system right now with what's expected and how we have set up the system, because it's not about general practice. We have set it up that way. They are doing exactly what they're asked to do.
Yeah.
How do you think we bring about some congruence in this changing, brave new world, Martin?
So I think we have to differentiate between acceptable variation and unacceptable variation. So variation in itself isn't a bad thing. Indeed, in many ways, variation is about personalization. And general practice, more than anywhere, needs to personalize, needs to be able to have that flexibility and that autonomy to make decisions that suit the patient and the community that you're serving. So, so I don't think you should pretend that all variation is bad. Some variation is bad, where it's not sustainable, where it's not defensible, where it's not based on good evidence. That's clearly not right. And actually, I would argue that we've done a lot of things over recent years, over the last 10, 15, 20 years in order to address that. You know, we've got a smaller number of IT systems. We've got only 2 or 3 big providers now. We've got much better data sets coming out. We've standardized as a consequence of QoF, and I'm not a complete QoF advocate, but actually as a consequence of QoF, we've standardized long-term condition management. We're much better at evidence-based care than we used to be at the beginning of my career. So I think there's many ways in which we have reduced unwarranted unnecessary variation in order to deliver better care for everybody. So there's still a long way to go, Mo. You're absolutely right, but I think we're in a much better place than we were.
I absolutely agree with you. I think we are in a better place, and I think it does give people some assurance that we are moving in the direction, that there is need to recognize that variability is not always bad. It's about recognizing the unwanted variation. I think that's often what some really good comments in the chat box about GP retentions, about supporting mothers who want to come back, making the workplace better, accepting that. And I think some really good feedback from people. And I think stuff that we need to start thinking as a community, how we will change the workplace so that there is more retention of GPs in the long term. And they really see themselves as valued, trusted colleagues who are making all the difference to the health system, not as people who are just having to work and see 50, 60 people in a day and then really tiring out, because that's not what we all came for. So Martin,
I think you're right, Mo, that, you know, we're coming back to scale again. In larger organizations, it's easier to provide that career flexibility for young mothers, for people who want to work part-time or want portfolio careers or whatever. It's just easier to provide that. And I think, you know, one of the great strengths, one of the great assets of general practice has been the ability to be more flexible in the way that you work. And we need to carry on promoting that. Really important.
And Martin, before we start coming to a close, any wise words for us to start thinking about what the future would hold for GPs? Where are the aspirations? Because some of us have done 30 odd years now and are looking towards the end, but there are loads of young people coming, loads of young talent. They will be the leaders who will lead this tomorrow. What should they be thinking about? Developing themselves, becoming leaders in the system, and how should they put this forward so that general practice continues to have a really strong voice in tomorrow's health and NHS? Because there is no NHS without the general practice.
Yeah, absolutely. So a number of bits of words of advice, and I guess, you know, this is based on my experience through my career. You know, why, as I approach my 60th birthday, am I still buzzing about general practice? You know, I guess it's because I've always retained, maybe through my research work, I'm not sure, but maybe by personality, I've always been able to retain the ability to think kind of strategically, to have the helicopter view of what's going on. So never to be too dragged down by one particular problem or one particular stressor. So I think I've that ability to see the big picture, to see how important general practice is and what we have to do in order to promote general practice in the wider system, I think has kept me going and kept me engaged and kept me energetic. I think developing leadership skills is really important. I think you're absolutely right about that. And, you know, I guess, you know, most of us who become doctors or become senior health professionals have got some leadership abilities, but there's nothing like doing leadership training and then rolling up your sleeves and getting on with it and testing out and developing your leadership skills in order to understand how to influence. And that's what this is all about. If we don't have a significant number of clinicians who are able and willing to get in there and influence people around them, general practice won't have the voice and will wither on the vine, and that's a problem. So the onus is on all of us to develop our leadership skills, sometimes at a local level, sometimes at a regional level, sometimes at a national level. I've worked at all three. I think is really, really important. And then finally, I think particularly at the moment when things are so tough, try and retain a sense of optimism. I think that's really important, and that's about having this vision that general practice has been through tough times in the past, and policymakers always eventually get it. They usually get it too late, but policymakers do understand that general practice is important and will invest in general practice and make general practice strong again. So whilst this is probably the worst crisis that I've seen in my 30-year career in general practice, it will get better again. General practice goes through cycles, and we just happen to be going through a really tough one at the moment. Things will get better.
Fabulous, and really good words to end on, Martin. Keeping the optimism going and recognizing that general practice is the mainstay of the health system. And if we keep that flame alive, if we work together on that, it'll be wonderful to get this right. Martin, I can't thank you enough for your time today. It has been absolutely brilliant, and the evening would never have been as good without someone like you speaking so freely and sharing with us your thoughts. May I also take a moment to thank all the participants, because there are almost 50 of you online today, and the event's never good enough without the questions, without you all taking an active interest. So I'd like to thank you all for your time. 7 o'clock in the evening, many of us would like to have a glass of wine. I'm sure many of you have got that in your hand, but hopefully you found this conversation riveting and interesting, and it's going to keep general practice live for a long, long time to come. Next month, in a similar series, we will have Rosie Bennyworth, who is the Chief CQC Inspector for Primary Care, who will be sharing with us her thoughts. So please do register for that event if you'd like to join for that. And just before I end, may I sound a big, big thank you and clap to Janet, Sarah, and Ruth, who have been fabulous in keeping us going today, so that we've had this great evening while in the background they've made this happen. So thank you, everyone, and have a great evening. Thanks, Martin. Take care. Bye.